Morning. CS PHP theory paper had therefore basis made price for evaluation. Abhi tried and obviously direct person on price. So the significant version of evaluation from initial price. And it's always a good exercise to look at what are the price in last 1 year and what are the important ones long run. Okay, I'd like to pick up four major events. ACCA, APCT, last 1 year. There are more than 100 of them. Picking up important ones is also a very difficult task, but I try to do whatever possible. So, better to group them as basic acute coronary syndromes, chronic coronary syndrome, heart failure, drives like that. Divide that way, maybe slightly easier. And among the acute coronary syndromes, four types stand out, and is smart choice, reboot, DNIC, and beta and MI, and clears energy, and not many other things. We will take the main messages from the important ones. In 2021, it was a default class 1 indication to give DAPT for 12 months. So the second molecule could be either molecule or focus on at least 12 months was the class 1 indication. And then the comparison among the three molecules, Tirazil and Prasugrel were preferred. The leading list is more probably Clopidogrel was to be preferred as a monotherapy after DAPT is stopped. And with this, there are a number of trials which try to shorten the duration of DAPT. 3 months, 1 month, like that, there are a number of them, and what has been continued as monotherapy was between either as Ticagrelor, Prasugrel, or Clopidogrel. So, 2 years back, maybe important trials were global leaders and after DAPT. Last year, there was a trial on ultimate DAPT, which has shown that giving Ticagrelor aspirin for 1 month, followed by 12 months of monotherapy, was as good as using both for 12 months. So, you can go for 1 month DAPT followed by de-escalation, and the results of the events, the infinite events are reading this similar. That was the conclusion, so it has given a lot of important messages for changing the guidelines. It was followed by another trial this year, that is choice 3, smart choice 3, where actually they tested a large number Clopidogrel, which has shown that after 1 month of DAPT, even Clopidogrel, the rest of the period is as good as Ticagrelor. So it is a very concept changing trial. Then there are other small trials like dual ACS have shown that 3-month DAPT is as good as 12-month DAPT. And DO mindset has clearly shown the excessive risk is there only in the first 1 month after an ACS. So the 2025 guidelines have given a class 1 status for use of Prasugrel or Ticagrelor after just 1 month of DAPT. So this is an important jump from previous guidelines. It could change our way we practice. Those who are already there is need for giving oral anticoagulants. The second drug is preferably not aspirin. Maybe either any of the P2 by 12 inhibitor, but clopidogrel is more preferable during this case. Then what about use of beta blockers for acute MI? When there is reserved ejection fraction, the controversy is more acute, whether it is at all rational to give for many years beta blockers to be continued or not. There is one trial, reduce AMI in 2024, which has shown that it's not good to give beta blockers beyond first 1 year. Then previous trials has shown that those who are on beta blockers, continuation beyond 1 year or discontinuation have no difference. So previous trial was somewhat more in favor of continuation. The patient is already taking beta blockers and stable, don't have to change it. What previous trial has shown last year. This year there are two other trials. One is the reboot trial and another is beta MI can block trial. When the first trial has shown that there is no difference of the event between the two arms, but beta MI can block has the Denmark trial, which has shown that beta blockers have definitely lowered the death or MACE by using even beyond 1 year. So we left at a very confusing state, what is to be followed. Probably the message is the every function is preserved. We don't have to insist on continuing the beta blocker. Then another important molecule is colchicine, which had been tried in various situations. One is stable angina and another is acute MI, where Colgate trial has shown is good to add after MI. There is decrease of events over 4 or 5 years. Similarly, protocol 2 also has shown, but there is still one more trial recently published, that is clear OSS 9, where larger number were randomized to colchicine or placebo, and they found that acute and long-term colchicine did not reduce the event or death, and it was in fact associated with increase in diarrhea. And this is the largest trial of colchicine after MI, and so now there is no evidence as such to use colchicine after acute. Then the trial called the danger trial, that is Impala, use of Impala after acute MI. This is in the setting of COP IABP trial, which was a negative trial. This is a positive trial, but on long-term follow-up over 3 years has shown that the acute kidney injury and the need for renal replacement was higher. Those who were managed with Impala. Then there is a small trial of the immediate ECI by IFR compared to deferred cardiac stress MRI for non-culprit lesion in multi-vessel PCI, whether to do for the non-culprit significant lesion or not. So this says that better do cardiac MRI rather than on the table decision of IFR. Then trial intracoronary injection of RTPA did not improve the microvascular obstruction. Trial and pulse trial, routine use of cardiac angiogram for unprotected left main disease that did not give any additional benefit than routine CD angiography test. Then coming to chronic coronary artery disease, there are a number of trials. Various trial is about Minaka. Minaka, all of you must have now be familiar with that after the fourth definition of MI, fourth universal definition. But the mechanisms can be varied. So we can't always prescribe a particular standard therapy. But by giving to one arm, intense statins and intense maximum tolerable AC inhibitors, one arm was treated and another was standard routine usual care. They compared the two groups and there was no much difference. That means we don't know how to treat Minapa in the best way. So probably it needs further research as to how to treat Minapa. That is, am I that angiographically epicardial vessels were near normal? There is no objective reason how to manage that case is not standardized now. Then using of oral anticoagulation, additionally whether aspirin should be given or not, this particular trial has shown that by giving aspirin, the harm is more, there may be more risky outcomes, increased death and bleeding. So when you are giving triple therapy for in a CAD case with atrial fibrillation, don't use aspirin as an additional aside from this particular recent trial. Then multi-vessel PCI versus CAD. This has been over a decade. There are a number of trials starting from body, arch fluid, syntax, freedom is diabetic subset, which all have given an edge to CABG as the preferred method of revascularization. The recent Innovate Complex PCI trial has designed this trial to compare angiographic guided versus CABG and image guided PCI versus CABG. So when they have used imaging as an additional tool to decide about VCI, the multivessel disease, was equivalent to CABG. So this is an important trial that has shown that using imaging and deciding the need for VCI of a particular region in multivessel disease is better than just eyeballing on angiography and deciding. So we can produce near equivalent to CABG results by using imaging. So this is an important additional benefit of using imaging, further imaging appropriately and get the maximum benefit of the. Then there are at least two important trials which made India proud. One is Tuxedo 2. This was presented by Dr. Upendra Kaur, who is known for several first international arena. This is FFG company's Supra plus sirolimus eluting stent. Almost people study done about 10 years back. Epitaxial eluting stent was not performed as good as everolimus by the same group of investigators. But this year we presented data where ultra-thin stent Supra plus stents were as good as everolimus is taken as the gold standard. And the events were equivalent. So at least this is a common thing for the sake of students. I want to clarify that any new device or new drug in cardiology or medicine in general has to first prove that it is equivalent to other drugs. First they have to say it is non-inferior. Then you have to show it is equivalent, then you have to say it is superior. So there are three stages. So it has been proven as non-inferior to equivalent. So it's an important trial both because it is made in India and presented at international level and has been accepted. Same company has the same device has been tried in multi-vessel disease and is presented by Patrick Series, who is well known investigator in coronary artery revascularization. Where except this device has been used and it has proven as good as synergy stent is also taken as very high-end and beautiful stent. And the events are equal. This is again made India proud trial. Because likely that some investigators who are involved in these trials may come as your examiners, better have some idea about such trials being presented at international level. Then drug coating balloons are becoming more and more popular. There's a lot of scope for them in gray areas like instant stenosis, de novo small vessel defined as less than 3 millimeters, or de novo large vessels where you don't want a stent, you want to achieve the natural endothelialization after the procedure, or bifurcation region where you don't want to put two stents, both in main and side vessel, or in high bleeding risk, whether you can use a single antiplatelet by using drug-eluting balloon rather than stent, and diabetic sepsis where diffuse disease is more common. So these are the areas where drug-eluting balloons have been tried, and one recent trial this arena is back phase 3-1 is a 3 years follow-up of two arms. One is drug-eluting balloon with rescue DES on arm, other is standard DES use. 2 years the follow-up did not show non-inferiority. However, 3 years, again they compared and they found that the events were more in by using drug-eluting balloon. In contrast to this, there is one more drug-eluting balloon, two more trials with drug-eluting balloons. One is pollutant de novo in de novo lesions. Here it was proven as non-inferior to routine TES. Second is ISR, that is instant restenosis. Though the numbers included were less, for the first time they have proven that drug-eluting balloons were non-inferior to standard of care. So it is a revolutionary finding. So more and more you will see drug-eluting balloons market as well as our labs. We are likely to use more of them. Then calcified leads, now beyond rotablation, we are using IVL. So IVL has been almost a gold standard. Other devices are getting compared with that. There are at least two trials, TCT recently. One is short-term trial where they compared IVL with cutting balloon, where cutting balloon have shown non-inferiority to IVL. And victory trial, the cutting balloon did not get the non-inferiority when you compared with atherectomy. So atherectomy is slightly better than using cutting balloon. Then Dr.A trial, the classical teaching of graft disease. If graft disease occurred, whether to attempt the native vessel or SVG graft, that is always a dilemma. I was thinking native vessel may be easier and better if it is possible, but this particular trial says PTC of the SVG is much better than trying the native. That's the message from this trial. Then artificial intelligence is coming up very big, and such a rapidity, they are all becoming outdated. Probably older generation cardiologists will be outdated very soon because AI is more familiar with youngsters here. Just come into diagnostics, management, and decision making, and precision medicine is now coming up like anything. So to precisely take the help of AI and decide what to do. And also it is likely to reduce the fatigue on doctors, like you don't have to report 200 ECGs per day. AI will do it for you in short time. Or echoes also are not now getting analyzed by AI, and you are getting very good reports in shorter time. So time is saved. The doctor's fatigue is definitely going to reduce. So AI-based ECG analysis of semi bias. And speaking of semi and periphery, using AI has been tested this particular trial, where they could see that more semi-like presentations are more truly diagnosed as semi by AI than the physicians are the primary physicians who see the ECG for the first time. So AI is becoming a better tool to do it. Second is AI related part TT coronary block assessment among men and women has also given an edge in risk stratification. So AI can decide whether the block is more vulnerable or less vulnerable, more likely to have events. So our aggressiveness of preventive therapies or strategies can be decided on AI-based CT scan analysis. So the CT scan may not be done for the cardiac reason, may be done for other reasons, for other purposes also. You can still get data from the coronary structure incidentally recorded by the CT scan. So it need not be just for that sake. Then among the risk factors, submit trial and sole trial are step up and step up diabetes. Can anyone tell what molecule I'm talking about? Semi-retard. So, I think there was a question about submit trial. Submit trial was presented in AHA 2024, where Preparatory was tried for heart failure with without ejection fraction and obesity. It was a positive trial. There were lesser events in the study group as compared to placebo. So compared to placebo was definitely helpful. That means cardiovascular benefits have been found by TPL1 interval. Gold trial is almost similar. Now all of us have been learn more and more about semaglutide because obesity is on the increase in India as well. So many young obese patients are coming with cardiac events. So it is high time we learn more about them and use them appropriately. Now it is in Indian market quite popular. With another positive trial, step up and step up type 2 diabetes. Two arms were there and they have shown very positive results. Greater weight loss and metabolic benefits are the significant. Then Victorian reshape. The molecule is inclisiran. Now inclisiran is a very important molecule in the market. It costs about 95,000 now. And I think they must have reached most of our hospitals and already promoting it. Probably two aspects have been recently studied. One is whether we can give it in ACS as an initial dose after MI. Second is whether it can be used as a monotherapy if there is statin intolerance. So there are two trials which have shown that the LDL reduction is so good as much as 50 to 60%. They are very important molecule. Another important advantage is it can be almost like vaccination, every 6 months. So compliance is better, it's easy to convince. If it is direct with insurance, probably we can do much better job of giving it to larger populations. So insulin is a very good molecule which is coming up and it is now shown to be superior to other molecules like histamine and given along with statins or even as monotherapy, they are quite good molecules. Then newer molecules are coming up for treatment of hypertriglyceridemia like polychestan and lot of drugs are coming for LPA. Hypoprotein small a, when we were students, Dinos and Dinos was going to several centers in
I was
India
doing
and was
something
talked
else,
about
something and typing.
LPA is an important risk factor, but nobody listened to him. They were not in the guidelines for many years. Now again, these are things of interest in LPA. Those days only niacin was the drug which may be used for LPA, but it is not well tolerated drug. It causes a lot of flushing, so it was not very popular. Now, very good molecules are coming up for reducing lipoprotein small a Number of trials are coming, and some of them are already published. And Essence TV 73B is a trial with polyjacent in hypertriglyceridemia. A significant reduction of even FOB is seen with this particular molecule, so it may become an important molecule in our dyslipidemia management. Then the hypertension, there are recent hypertension guidelines. 2025, there are two guidelines. One is ACS guidelines and another is hypertension guidelines by AHA. And PSP have guidelines on focused update of dyslipidemia. I advise all of you read those things. Of course, there are a few other guidelines which may or may not be right, but these three everyone should read it. So the offspring is again, can anyone spot with this gentleman? Prabhakaran, very good. First place, madam. Yeah, he is very popular now. He was in Hyderabad for some time and he is associated with several Indian trials, epidemiological trials, and he has published several research papers from India and he has presented this paper AHA offspring. Here they have tested uploaded with parentopril with indapamide, uploaded with indapamide. I think about 2,000 patients and shown that they are very safe, compliant, is very good, and discontinuation is very less. So he made us again proud of Indian research offspring. Because in Indian trial, some of the examiners may ask about this trials or better know about it. Then aldosterone synthase inhibitors, baxdrostat and lorundrostat. Can anyone tell what are the trials associated with this? Very good. That's hypertension, lorundrostat. These are how useful molecules for resistant hypertension. The trials have shown that they are very useful. This is RACS hypertension trial. This is a positive trial. Then advanced hypertension is a lorundrostat trial. Then pill-based therapy. What is the importance? This is a trial in cardia 1, 2, 3 trials. This can be given as subcutaneous injection. So this safe, so it has not met the primary outcomes. It is shown, it is thought to be very promising molecule. Anything which is given injectable is popular with Indians because we can improve the compliance. And other trials like street trial, BP road trial, in fact, BP trial, I just speak for want of time. Heart failure, there are a number of trials. Quickly, I will tell some of them. Why not trial? Everyone is familiar, I think. This is a non-steroidal. What is the molecule? Oh, yeah, it is there in the market. Across using more than us. But still, I think the new molecule to be mastered by the cardiologist, positive trial. Then, ALT shock trial. Again, early use of IABP in heart failure complicated by shock trial, which is again negative trial, not a positive trial. Then iron therapy in chronic heart failure. Initially, there was a lot of enthusiasm to give it following the trials like failed heart failure, confirmed heart failure, affirmed trial, because iron deficiency is quite common and prevalent. Recent trial is failed heart failure, true trial and Ironman trial. Both are negative trials, but they are not fully negative. Three guidelines recommended as 2A indication. Iron therapy. So then megacantum and epicant. What are the trials associated? Yeah, Explorer HCM, Tyler HCM. Recent ones are Apple HCM. So Apple HCM is epicant trial in obstructive HCM was a positive trial. But Odyssey HCM was tried in non-obstructive HCM. It was a negative trial, not a positive. So when there is no obstructive variant, this may not work. So the negative trial. Then reshape heart failure. That is, MT is done just to reduce the mitral annulus and reduce the MR, functional MR, and it is a positive trial. Then relieve heart failure is creation of interatrial shunt in heart failure with reduced ejection fraction versus greater ejection fraction. They are compared, and in reduced ejection fraction, by doing this, there was benefit. And in preserved ejection fraction, we didn't show any benefit. The creation of hydrogenic interatrial shunt. Then these digoxins coming back again to the question or in the background this is done. When you properly select, it was a time when digoxin was the only drug when we were medical students. After that, it faded out. They said it's not useful following several trials. But this is one trial, recent trial, where 1,000 odd patients of reduced ejection fraction patients were randomized to digitoxin versus placebo. And they found that there is significant difference in the primary events, if not secondary outcomes. Probably properly selected patients, it still has a role. So it is not out of our trial. Then valvular heart disease, align AR trial is TAVI for isolated AR, without AS. Then TAVR unload, TAPA TAVI, partner 3, low risk follow data. Then these are all very encouraging. Large numbers have to still come because there now registries have been created for each novel procedure, and more numbers are getting added to that, and we will get further details. Then Kappa TAVI is again use of Kappa deposit in post TAVI, and it is found to be useful because most of them are elderly, most of them had AS, most of them will have this vascular dysfunction. So Kappa deposit is a benefit. And partner 3 is again benefits have been persisting even at 7 years. So it continues. Partner 3 low risk group. So it is a procedure that is to be adopted. And my valve is Indian valve again. So there is a trial on that, that is landmark trial. So it has shown that it is as good as any of the standard multinational devices. And devices for MR and PR, now they are becoming more and more popular. See the pictures, we get some idea. First one is Ryzen device, second is EMPR, Capian M3 device, is something like a coil here. Actually, I think probably that will reduce the angular size. Then you have to switch down. And submit AMC file is where specific material annulus is there. This is the type of device can be used. You see the length of the other button is beyond the apex. See, this goes all through the LV and outside the LV, the other button is there. So that it will cause reshaping of the LV also. This is still in the early stages. And about EP and NOVAX, there are a few trials. Like rivaroxaban has been compared with warfarin. Rivaroxaban was proven to be non-inferior to warfarin thrombus, LV thrombus. So there are no good drugs or standard therapy for with LV thrombus. If at all any benefit is there with warfarin, equal benefit can be obtained by rivaroxaban. Then alone AF as well as lead paracetamol. We are seeing paracetamol area doing pulse field ablation. This is slightly different from MS, where you may keep some vulnerable areas. This will better ablation field and the results are proven to be better. Now it is now more used pulse field ablation. Okay. What area? This is a trial where if you are doing holter for 14 days, people above 70 years, some of them will have asymptomatic intermittently. Whether such strategy is good, here they have shown that such a strategy may not benefit. So the two arms were not much different. Then, is there any need for ICD after MI? If less than 35%, already 40 days are over, there is indication for ICD. But what about a group where the EF is above 35 but less than 50? Then ICD is of any benefit or not? That has been studied this particular trial, that is a refined ICD trial. I don't know how many of you have written correctly, but this is the subset. This is a trial which was going on for 14 years. Only 597 patients were recruited, and ICD did not reduce the all-cause mortality, cardiac death, or sudden death compared to usual care. So when EF is more than 35, even 40 days are over, ICD should be put according to this evidence, right? Then three trials I will tell and conclude the session. Genix trial. What is Genix trial? Anybody? What are very good. Then CAN 2 is about high dose influenza vaccine, whether it will reduce TB events or not. TOM P is pulmonary embolism. Aspiration. That is Penumbra, which is becoming more and more popular. So Genix trial has shown that solar therapy is very useful. It reduces the relative risk of events by 76%, but it's very costly injection, very costly. Thank you. Thank you is just I told. It's a positive trial, but it's not very strong conclusions are not enough. And what about high risk acute pulmonary embolism? There are several ways of tackling the thrombus. Of all, nowadays the Penumbra device has been more and more used and compared with other devices like AngioVac and flow fever. This is the recent trial from B, which has shown that device is very user friendly and very effective, and this trial is very encouraging about catheter based. So coming to the guidelines, there are a number of guidelines, but important ones I have already told. That is ACS guidelines by AHA, that is in 2025, and hypertensive guidelines. Then in hypertensive guidelines, the important thing is to better to think of primary aldosteronism in all the registered hypertension cases and investigate for it. So there is more emphasis on investigating that, and about renal denervation therapy. There is honeymoon period for it. First they said it's good, then they said it's not good. Then by changing the devices and the technique, it is said to be tried better. Now what the current standing is, it is 2A indication for refractory cases. That too after using 3 drugs, it is not giving much benefit, you might try it. Then there is also chronic stable angina. There is large trial by ESC, very good document. I advise those who are not read to read it. Thank you. Best of luck.